Hi, good morning, and welcome to the National Health Council's release of Access, Affordability, and Quality, a patient-focused blueprint for real health equity. We're very excited to have all of you with us today for this important discussion. I'm Eric Gasho, Vice President of Policy and Government Affairs at the National Health Council. For those of you who are unfamiliar with the NHC, our membership consists of more than 140 national health-related organizations and businesses. The NHC's core membership includes the nation's leading patient advocacy organizations. Other members include health-related associations and nonprofit organizations, including the provider, research, and family caregiving communities, and businesses representing biopharmaceutical, device, diagnostic, generic, and payer organizations. Many of these organizations helped us put together what we're sharing with you today. Our mission is to provide a united voice for the over 160 million Americans with chronic diseases and disabilities. This morning, you will hear from patient community leaders and one of Congress's leading voices on health equity. We will discuss the importance of advancing health equity and give an overview of the work of the National Health Council is leading to bring the patient community together to address longstanding barriers to care to far too many people. Before we get started, we have a few housekeeping items. We'll be taking questions at the end of the session in the chat. Please feel free to type them in as they come to you, and we'll make sure we get to as many as we can at the end of the session. All participants will remain on mute. If you have any technical issues, we'll put the number in the chat, but we have a tech support line at 773-645-3877. A recording of the session will be posted to our website alongside the report after we're done. And with that, I would now like to introduce the speakers you will hear from today. First is LaVarn Burton, the President and Chief Executive Officer of the American Kidney Fund and the Chair of the NHC's Board of Directors. Next, we will hear from Representative Robin Kelly from Illinois, who is one of Congress's leading voices on health equity. Then we will hear from Randy Ruda, the Chief Executive Officer of the National Health Council. And finally, we are joined by Dr. Gary Puckrin, who is the President and CEO of the National Minority Quality Forum, which is a not-for-profit organization that addresses the critical need for strengthening national and local efforts to use evidence-based data-driven initiatives to guide programs to eliminate the disproportionate burden of premature death and preventable illness for racial and ethnic minorities and other special populations. NMQF has been a very key partner in the work that we have done over the last year and a half. So with that, first up, it is a true honor to introduce the President and Chief Executive Officer of the American Kidney Fund. The Kidney Fund, LaVarn Burton. The Kidney Fund is a national nonprofit organization whose mission is to fight kidney disease and help people live healthier lives. As I previously mentioned, I'm very honored that LaVarn is also serving as the chair of the NHC's Board of Directors this year and has been a true champion for health equity and a great leader within the NHC community. So really excited to turn it over to LaVarn.
Thank you so much, Eric. I'm delighted to have this opportunity to kick off the program this morning and to have all of you join us. To start off, I want to share with you a little about the importance of this effort to patients and the commitment of the National Health Council. The patient perspective is key to addressing health equity. For too long, discussions have been made about healthcare without real input from patients, let alone patients who are marginalized and from marginalized communities. This is one of the reasons that we have the inequities that we see today. For example, kidney disease, which is the focus of the American Kidney Fund, where I work full-time, impacts people of all backgrounds and demographics. However, people of color disproportionately progress to kidney failure much higher rate than others. And this is due to the lack of health insurance, the lack of healthcare providers, and other inequities in our healthcare system. We need to reimagine our healthcare system so that it is responsive to patients and drives equity. While Congress and the administration have a role to play by crafting meaningful policy, so do those of us in the health ecosystem by engaging patients and re-envisioning our policies and our practices. The National Health Council will do this by leveraging its multi-stakeholder membership to help drive change. The National Health Council has always been focused on making sure that our health ecosystem listens to and meets the needs of patients. And this includes patients from marginalized communities. We have led efforts to help infuse the patient voice into healthcare, which leads to greater equity. However, over the last few years, those efforts have had a renewed focus and urgency. And we know that patients are the best to deliver the message on the nature of that urgency and on what needs to be done. As the national focus around equity has advanced, we have seen a tremendous amount of work and progress toward advancing it. However, we know that these efforts will not be complete unless they include all perspectives and especially include the voices of the broad patient community working in concert with the rest of the healthcare system to make needed changes. As National Health Council Board Chair for this year, I am committed to making sure that this organization is front and center, as are other members of the National Health Council. We will be working with our membership and the entire health ecosystem to address health equity. This is the lens that we will be looking at in all of our decision making. The root causes of disparities go back many generations, and meaningful, lasting change will not happen overnight. Therefore, the NHC has taken a deliberate approach and made a long-term commitment to the issue. One indication of our commitment is our recently completed strategic plan, which for the next 3 years prioritizes health equity as one of our core pillars. The leaders of the nation's patient groups have committed to working together to end structural discrimination in the healthcare system and align on a successful strategy for reform. Patient organizations are uniquely positioned to lead the health ecosystem towards equity, particularly for people with complex chronic conditions and disabilities. We commit to elevating the patient voice, and we call on our nation's leaders inside and outside of the health ecosystem to join us. Now, I am thrilled to introduce Representative Robin Kelly from the 2nd District of Illinois. While Congressman Kelly unfortunately could not join us in person, she did send a video. Representative Kelly is a leader in congressional health equity efforts. She serves on the Energy and Commerce Health Subcommittee, Congress's main policy writing body for healthcare legislation. And she chairs the Congressional Black Caucus Health Brain Trust, one of Congress's principal health equity advisory task forces. These roles place her at the nexus of legislative efforts to ensure equitable, quality, affordable healthcare. She and her colleagues in Congress are key partners in achieving our goals, and we appreciate Representative Kelly's leadership. And here's her message.
Hello, everyone. Thank you for inviting me to speak to you about some of our upcoming health equity priorities for the remainder of the 117th Congress. I also want to thank the National Health Council for organizing this important conversation. Healthcare and healthcare access are some of the most important but also challenging issues facing American families. We all want to keep ourselves and our families healthy, but too often families experience barriers to care, lack of access to care, or unaffordable care. We need to work towards promoting health equity in our communities, increasing diversity within the ranks of healthcare providers, and expanding innovation at the intersection of technology, telehealth, and telemedicine. And as I want to urge you to prioritize today, we need to increase diversity in clinical trials. Addressing our nation's health inequities requires a dedicated and holistic advancement of access to quality and affordable health care, as well as increased access to clinical trials and research. Scientific and medical research not only creates well-paying jobs, but it also improves our long-term national health by promoting cutting-edge research that will develop the next generation of cures that will save lives and further reduce healthcare costs for everyone. The COVID-19 pandemic has only shed more light on how pervasive health disparities are across the country. The pandemic has disproportionately affected Black, Indigenous, and Latinx communities, all of whom have experienced higher rates of COVID-19 hospitalizations and deaths. One factor underlying the COVID-19 racial disparities is health disparities in chronic health conditions. 80% of Black women are overweight or obese compared to 64.8% of non-Hispanic white women. Black Americans have higher mortality rates for many cancer types, including breast cancer and prostate cancer. Latina and Black women have higher rates of cervical cancer than women of other racial and ethnic groups. American Indians and Alaska Natives have higher death rates from kidney cancer than any other racial or ethnic group. Decades of institutional racism have hindered healthcare access and worsened these inequities. These staggering statistics not only highlight the health inequities, but also highlight the need for inclusive clinical trials for treatments aimed to address these and other conditions. For centuries, the health of Black and Brown Americans has been cast aside as an afterthought. Even when data has shown us pervasive disparities in healthcare access and in disease and treatment rates, our healthcare system has not prioritized those issues. Additionally, there have been a shocking lack of consent when it comes to experimenting on Black bodies. There were gynecological experiments on enslaved women without anesthesia. Only after these experimental techniques have been perfected at the suffering of countless Black women were they performed on white women who were anesthetized. There is a story of Henrietta Lacks, whose cervical cells were used without her consent to advance research around the world. Without her knowledge, her cells were taken and kept by a scientist and eventually used to develop cancer treatments, the polio vaccine, gene mapping, and in vitro fertilization. We all know the enraging story of the Tuskegee syphilis study that subjected a group of Black men to untreated syphilis even after penicillin had become available as a treatment. Untold suffering was brought upon Black people under the racist notion that Black people could not feel pain the same as white people. Even more shocking is that there are some people who still believe this today. We must do more to dispel these harmful and hateful misconceptions, and we must find a way to address those decades of trauma and abuse while increasing diversity in clinical trials. We need to do better and work with patients, providers, and community leaders to build effective communication strategies and rebuild the trust needed to have more inclusive clinical trials. A 2018 study found that the 5 major barriers to diverse patients' participation in clinical trials include mistrust, lack of comfort with the clinical trial process, lack of information, time and resource constraints, and lack of awareness about the value of clinical trial participation. Scientists and researchers need to rebuild trust with Black communities and with communities of color more broadly. Enhancing representation in clinical trials is an important first step that can help provide more information about the safety and efficacy of new treatments in populations that have been historically underserved. In addition to ensuring that there are more Black, Indigenous, and people of color in clinical trials, we also need to ensure that scientific researchers and providers are diverse as well. Diversifying the scientific and medical workforce will help restore trust from the community and help to better communicate the value of participating in clinical trials. In Congress, as a chair of the Congressional Black Caucus Health Brain Trust and a member of the Energy and Commerce Health Subcommittee, I am deeply invested in closing the gap on health disparities. This includes diversifying clinical trials. To that end, I am currently building support for my bill, the Clinical Trial Diversity Act, which would 1, require NIH to work with clinical trial sponsors to develop clear and measurable diversity goals based on disease or condition prevalence. 2, empower NIH to use existing penalties if these goals are not reached. 3, ensure the availability of less burdensome follow-ups for patients participating in clinical trials, such as fewer follow-ups or virtual follow-ups. And 4, launch a public awareness campaign across federal agencies. I am hopeful that this legislation will expand access to clinical trial participation and ultimately result in better science and information to treat conditions for which we still need to develop or improve treatment. I am always looking for opportunities for us to address health disparities in Congress and close the gaps in care that too many Americans face. I hope that you will continue to keep me informed of your ideas and data highlighting how we can tackle health disparities. Finally, I want to encourage you all to continue this very important work. As pharmaceutical manufacturers, developers, researchers, and practitioners, you have the opportunity to improve our clinical trials, increase equitable healthcare access, and help to eliminate health inequities. I am looking for your feedback and support in my clinical trials diversity bill, and I hope to hear from you soon about this important legislation. Please contact my Senior Health Policy Advisor, Dr. Anita Burgos, at anita.burgos@mail.house.gov to support the clinical trial diversity bill. Again, thank you for inviting me to speak today. I hope you have a productive conversation.
Well, thank you so much, Representative Kelly, for those inspirational, insightful remarks. You know, we're pleased to collaborate with Representative Kelly in this important work. I'm Randy Ruda, the Chief Executive Officer for the National Health Council. And I'm joined by my colleague and friend, Dr. Gary Puckrin, President and Chief Executive Officer of the National Minority Quality Forum, who also serves on our board of directors at the NHC. Now, the National Minority Quality Forum has been a key partner to all of our health equity initiative, providing key insights and expert counsel to help the National Health Council shape our understanding and efforts to improve health equity from the onset. Gary, would you like to comment on how we began our work together and what's happened to date?
Thank you, Randy. It would be my pleasure. We are proud of the work we have done together and the work we'll be doing going forward. This specific effort began in 2020 in an effort to coalesce the patient community and focus our efforts on health equity. Our two organizations worked together to convene a roundtable with thought leaders from across health sectors to discuss health equity. As a result of the roundtable, the National Health Council and NMQF issued a call to action asking our partners in patient advocacy to address structural racism in the healthcare system and align on a successful strategy for reform. Specifically, we asked our partner organizations to join our efforts to promote inclusive, equitable, and high-quality care delivery system, guarantee everyone has equitable access to affordable and comprehensive healthcare insurance, address inequities in the social determinants of health and result in health disparities, ensure the biometrical and health service research and the health equity ecosystem support equity in development and evaluation of new and innovative treatments and services. Patient advocacy organizations are well positioned to advance efforts within the healthcare ecosystem to achieve equity. We commit to elevating the patient voice, reframing conversations to prioritize managing the health, financial, and other risk patients face over managing financial liability to health systems. We know that if we can create a health system that works for marginal populations, it will benefit all people. And 58 CEOs of the nation's leading patient advocacy organizations signed on to a consent statement committing to reprioritize and focus on the 4 key pillars we have identified. We are thrilled with the response and move to gather our partners from across the health ecosystem and other experts to plan next steps and develop recommendations that Randy is going to tell you about now. Randy?
Thanks, Gary. You know, 2021, despite the pandemic, was a very productive year. We built on the momentum of the consensus statement, as Gary just described, to drive significant progress toward achieving health equity in the very deliberate manner described by Lavarne in her earlier remarks. Undertaking this journey, we made the commitment that our health equity work be inclusive of all marginalized populations, regardless of race, ethnicity, disability status, economic status, religion, age, sex, gender identity or expression, or sexual orientation. I'll now highlight our process and the compelling results of this work. Throughout the past year, we convened the National Health Council membership and other thought leaders to make specific recommendations for policy changes to advance health equity in the 4 key areas identified as most important in our consensus statement. These are increasing equitable access to affordable and comprehensive health insurance coverage, developing an inclusive, equitable, accessible, and high-quality care delivery system, addressing social determinants of health to reduce health disparities, and increasing equity in development and valuation of new and innovative treatments and services. Now, a series of policy recommendations were developed for each area. Approximately 75 national organizations representing patient groups, providers, civil rights groups, insurers, the biopharmaceutical industry, medical education organizations, and other sectors had direct involvement in developing these priorities. Principles, statements, short-term recommendations, and more complex longer-term recommendations were developed in each of these key areas. These recommendations are distinctive in that they represent the patient perspective and were informed by input from a very diverse mix of viewpoints. There are some common threads or themes that emerged in our work, and they were the importance of accurate, comprehensive, consistent, interoperable demographic data, the need for clarity, usability, availability, and cultural and linguistic appropriateness of health information, increasing the representation of marginalized communities in the healthcare workforce, including in care delivery, education, and research. And we engaged a diverse and representative set of patients in all healthcare decisions, a key priority. We engaged all of our partners in identifying consensus recommendations that the patient community believe are most important from their varied perspectives, and that can be influenced through our collective effort. The recommendations that emerge represent a select set of issues that we are committed to addressing first. The breadth and depth of what we learned throughout the year-long comprehensive engagement process will inform all of our work in targeted areas for near term and in more systemic areas of need for change longer term. For example, recommendations for each area include, under access to coverage, closing the Medicaid coverage gap. It's a key short-term priority. A more complex issue from access to care is increasing the number of historically Black colleges and universities and minorities serving institution, medical, and nursing school residency slots. For social determinants of health, a short-term recommendation is to increase access to affordable broadband services. And finally, for medical innovation, federal guidance and tools should be created to help increase diversity of clinical trials. These frontline areas of focus that I'm sharing today represent just the tip of the iceberg of what we discovered in our convenings and other discussions throughout the year. A complete description of our priority equity recommendations can be found on the NHC website, along with many other resources and information, including a library of equity resources from our member organizations. That said, the National Health Council and our partners recognize that many other organizations and leaders have been working on equity issues for years. We respectfully acknowledge and applaud this work. With this report, the patient community is adding our unique voice to the larger movement, while supporting all health equity leaders in their essential endeavors, past, present, and future. Gary, would you like to add any thoughts on the process or these recommendations?
Thank you so much, Randy. I first want to thank the National Health Council staff. They worked collaboratively with us. It was a great joy and effort. I also want to thank the board and the other organizations that committed to this great work. And Randy, thank you for your leadership on on this issue. Health disparities and inequities in healthcare have long been a challenge, and it's exciting to see the patient advocacy community coming in to make great changes here. I am convinced that the patient advocacy community can be the catalyst for change. They're on the front line, working with patients every day, advocating for them, and now they're using their unique voices on the issue of inequities in our healthcare system. And I think they can bring a dramatic change to our healthcare system. It's a great work. The old healthcare system, grew up as Congresswoman Kelly would suggest during a period when inequalities and segregation were by law and by practice acceptable. Now we're in a different period, and we need a healthcare system that mirrors our future and our effort to bring our communities together. So I want to thank deeply the National Health Council for bringing the unique voices of patients together, because I think that they can be the leaders in the change that we need to have. So thank you very much. And Randy, I'll turn it back to you.
Thank you, Gary. I so appreciate you, your partnership, your expertise, your support of this important and promising effort. I appreciate your passion and compassion and the dedication of everybody on the National Minority Quality Forum team. We couldn't have asked for better partners, better leaders, and better experts in this space. I'm really excited to think about what we'll accomplish going forward. But now I'm going to pivot to describing what lies ahead for the National Health Council's Health Equity Initiative. The National Health Council is committed to addressing health equity via both short-term actions to achieve near-term impact and through longer-term ongoing strategies to realize comprehensive and sustainable change. Today, we are advancing the policy recommendations in this report as follows. We're driving health equity through our well-established channels of policy advocacy conducted in partnership with our National Health Council membership. This includes direct advocacy on Capitol Hill, regulatory work with federal agencies, and engagement with the administration on efforts such as the executive orders and federal demonstration projects in this area. Of note, while our policy agenda prioritizes the recommendations released today, the National Health Council is using a decision-making framework of processes and tools that apply an equity lens to every piece of legislation and regulation that may support our vision for health equity. We will take advantage of every opportunity, policy and practice to leverage and advance the findings from this process. For example, over the last few months, we've seen progress in policymaking that are relevant to our equity-specific goals. Congress has been considering legislation that would provide assistance for individuals in the Medicaid coverage gap, increase diversity in clinical trials, and provide Medicaid coverage for mothers who have just given birth. These are all reflected in our policy recommendations. The 2023 Notice of Benefit and Payment Parameters proposed rules include several of our health equity policy recommendations, such as support for patients navigating the health insurance system at the time of enrollment and after they've gained insurance coverage, ways to improve data collection, and the increased use of medical billing Z codes that document social determinants of health data, such as housing status, food insecurity, transportation access, and more, all highly relevant to health equity and eventually health outcomes. We will continue to convene thought leaders within and outside the National Health Council membership to explore solutions to those policy recommendations that were identified as more complex. Most of those recommendations need a consensus building approach to identify potential solutions, including continued research. We also recognize the need for community engagement to build political momentum to address these complex, more systemic issues. We will be expanding our health equity initiative to go beyond policy work and engage more of our partners' expertise. As LaVarn stated, we are committed as an organization to continuing this important work as reflected in our strategic plan. This will play out in a myriad of ways in activities such as development of tools and resources to address identified equity issues. working with our membership to support health equity work in their own organizations, elevating and amplifying the health equity work of National Health Council members and other partner organizations that are leading in these specific areas. We fully expect this initiative to continue to grow and evolve as we build resources, capacity, and more partnerships. None of this work would have been possible without the support of our colleague organizations, and I would like to thank the patient groups who have committed to take this journey with us. We are grateful to the individuals and organizations who have contributed hours and hours of their time to help educate us on important topics and shape our thinking on potential solutions. I also want to thank the organizations that have supported our efforts in health equity: AstraZeneca, AbbVie, Astellas, Bristol Myers Squibb and Gilead, Johnson & Johnson, Lilly, Sanofi, Amgen, Bluebird Bio, Mallinckrodt, Merck, and Bio. And finally, I would like to thank Jennifer Dexter, the National Health Council Director of Policy, who led the efforts to develop this report. She's an extraordinary colleague and a leader in this space, and I really commend everything that she has done to bring us to this point. Thank you all for your time and attention. I look forward to engaging you all in our continued work. And now I'll turn things back to Eric Gasho, who will moderate our Q&A session. Eric?
Thanks, Randy. I know we have a pretty big attendance here, a diverse audience of NHC members, congressional staff, members of the media with us here today. So we'd love to get to any questions that folks may have. If you can start to type those into the chat. While you do that, I'll answer the first question that I expect to come in, which is, will this presentation or the slides be shared after the event? Yes, it will. We will be posting the URL to a recording of this on our website alongside the report. And you have the link to it in the chat, but also we'll make sure that we email out the link to the attendees as well. So I'm certainly happy to field any questions after the fact as folks have a chance to digest this as well. If we're not able to get to any questions, we'll make sure that staff is able to follow up with you as well. So with that, have a couple questions to tee up with. First, I have a question for you, Gary. I sort of have to laugh a little bit every time we see a health equity event posted and they say, and we're partnering with the National Minority Quality Forum. So first of all, thank you so much for all the time that you've committed to work with us on our work. I know you're doing it with a number of other organizations as well. I'm curious how the work that the National Health Council is doing supplements and sort of dovetails with a lot of the other efforts that we know that are out there that are very important.
Well, first and foremost, and I really do mean this sincerely, the patient advocacy community has a very important role to play in this effort to bring health equity to the American population. So I'm excited about working with the National Health Council and it's taking its leadership. But we have to understand that this is really a heavy lift. I was thinking the other day that when I started to look and obviously we're working with a lot of different organizations, one of the questions that have really never come up is how are we going to finance this thing, right? We presume that health equity can happen inside the budgets that are there. I'm afraid not. We have a lot of work to do, and we need to have that conversation. Health equity means investment. It means that for those underserved communities where we have given them minimum rescue care, now we want to bring them into the mainstream of American healthcare. And we have to take the time to figure out what that is. I'll give you one precise example that troubles me every day. The average life expectancy for a patient with sickle cell is about 48 years. We've had really no new medicines for them until recently, where we are starting to really use genomic medicine, going in and actually reprogramming their DNA to eliminate sickle cell. So there are about 90,000 Americans around the country who live with sickle cell, most of them African Americans and Hispanic. That gene therapy that I just mentioned to you will cost about $1 million, right? So you do $1 million times 90,000 people, and you automatically understand we're just talking one disease and one challenge. But I could talk to you about hepatitis C, right? I mean, there are lots of this. And we've not been honest with ourselves to have the conversation about, so how do we finance health equity? And I think the patient community has a very important voice here. And so that's why I'm so excited about working with the National Health Council, because we're all going to have to get around the kitchen table, as they say, and figure out how do we do this to make sure all of our people have access to quality care.
Great, thanks, Gary. So there are a few questions coming into the chat. First one is a little bit on the process. Question is, were any rare disease organizations involved in the report? Great question. We know as it relates to the rare disease community, issues related to health inequities are significant. Thinking about things such as clinical trial diversity, when there's already a smaller population of patients with whom to find for clinical trials. There are often shortages of specialists in rare diseases. So you know, a lot of unique challenges within the rare disease community. I will say we certainly partner very closely with the Every Life Foundation for Rare Diseases. We also are working to support the work that groups like Every Life and NORD and a lot of the rare disease organizations are doing as well. So really letting these organizations that are solely focused on rare disease kind of lead the charge in this, but certainly partnering with them and absolutely considering the unique challenges that the rare disease community faces as it relates to health equity. So another question is about organ transplantation. Question says it is plagued by racial inequality. Yes, it is. And yet the siloed transplant system in the US has resisted reform. What plan does the NHC have to address equity in organ transplantation? Before I mention that from an NHC perspective, would certainly love to hear from LaVarn. Obviously, this is a huge priority of the American Kidney Fund. So love to hear LaVarn's thoughts on this specific issue.
Thank you so much, Eric, and thanks for that question. The American Kidney Fund, as a member of the council, has really also designed its own plan for focusing on health inequities. And there are 4 areas in particular that we want to focus on over the next few years. One has to do with prevention and early diagnosis. Another has to do with use of home dialysis. Third one with regard to increasing participation of community people of color in clinical trials. And the fourth has to do with organ transplantation. And we are developing now our plan. Also, we've put together a coalition of other groups who are interested in this to work with us. And one of the first things that we will be doing is doing some surveys of our own population. We are assisting for, in terms of transplantation, we actually help about 8% of the people who get kidney transplants every year are doing it with assistance from the American Kidney Fund. Our rate of transplantation for the patient population that we assist, which is really overwhelmingly people of color and low-income people, transplantation is higher among that group than it is in the general kidney disease community. We want to understand why our population that we're serving is doing better. And we're doing some survey in that work. So we do as an organization plan to focus on that issue.
Great, thanks, LaVarn. I would say it certainly fits in with a few key themes from the report as well, as it relates to decision trees and really making sure that standards of care are developed in an inclusive and representative way, and also supporting the work that the American Kidney Fund is doing. I think, you know, again, looking for those ways to make sure that we are identifying our lane and making sure we're supporting the groups that really are focused on these issues. So certainly look to be a key partner in the work that AKF is putting together. So another question, does the NHC or any others on here, I know folks have all kind of engaged with them, have a position on CMS's Innovation Center strategy refresh, which includes a focus on health equity and health system transformation generally, moving away from fee-for-service to a healthcare system based on value. Anybody would like to kind of take that one at a high level, and I can dive into a little bit of specifics?
I'll take a quick stab at it. First of all, we're incredibly grateful to this administration and its focus on inequities in healthcare. The president, when he first came in, issued an executive order to have all branches of government look at inequities, including healthcare. So we're deeply appreciative of that. The challenge for CMMI and Medicare and Medicaid generally is really a budget question, isn't it? Because if anybody takes the time to read the trustee report for the Medicare program, you'll quickly realize that it's challenged by the fact that the trust fund is running low, and so they have to address that. So now you're talking about addressing the trust fund issue as well as dealing with these inequities in healthcare. And that's why I'm suggesting to you that this really is a budget conversation that we have to have. And CMMI and all the wonderful people over there still have to operate inside current law. And so it's important that patient advocacy groups be part of that conversation as we think about how do we address these real challenges. We have 90 million Americans on the Medicaid program, and that program is bound by state budgets. So how do you do that? So these are really important questions if we're going to be serious about dealing with health inequalities.
Yeah, and I would also posit that the work that we've done with CMMI and other agencies within the federal government have really been focused on elevating the patient voice and making sure that patients are involved in all decisions related to their care. And I think that's a key priority of ours and has been with our engagement with CMMI to really make sure that as we are considering moving towards a value-based system, value to whom and how do patients actually define what is a valuable intervention for them. And I think that's a way both within our health equity work and certainly more broadly as a key pillar of a lot of our priorities, making sure that we're really meeting people where they are and ensuring that we deliver care that best meets their goals. And so I think there's a huge focus there and a lot of synergy as we see it with the goals that Liz Fowler has set out at CMMI. Mm-hmm. So another question we have, and this one we could probably spend an entire hour talking about all of the challenges and potential solutions and benefits of a better data system. So question that we have here is what strategies can we employ to ensure more comprehensive data sets, including from traditionally underrepresented populations? Gary, I might turn that one back to you as well. I know this is a huge focus of yours and has been since the founding of your organization.
Yeah, the National Minority Quality Forum, we have been collecting health data for about 20 years now. We have a database of over 5 billion patient records. We collect data on 160 million lives per year. It's hard work. It's harder than it should be. The challenges, it reminds me of the old feudal system when knights, they used to put toll booths on their land, and anybody who wanted to cross their land had to pay a toll, and the national government had to step in and get rid of those toll booths in order to allow a commerce to happen across the nation. We need that in healthcare. We have to free health data because we need to crowdsource it. We need to learn quicker. It needs to be easier. Even in government, there's these incredible barriers just to get government to release data. I see Congress all the time talking about putting more money into government systems to collect more data, but they never ask, do you actually get that data out? Does anybody actually have access to it? And I dare say that's a very important question. Our future is tied around our ability to analyze and use health data. And it's incredibly important, and we're just not doing a good job at it right now.
And Gary, I would just add to that, the National Health Council has been involved for the past several years, in particular, in trying to develop guidance for researchers in areas like real world evidence or core impact sets, looking at value and how value is determined. Just this coming Friday, launching a set of resources around the patient experience mapping to truly understand the experience of patients in whatever part of the healthcare system they're interacting with. That has all been done in partnership with PCORI and CMS and CDC and other federal agencies, with some attention to equity. And now with this report coming out and this renewed commitment, I think we can absolutely leverage those tools that really are meaningful to researchers in a way that address these equity issues. And I would certainly look to your organization as a key partner in that, given your broad experience.
And I'll add a couple other additions to the data question. I think it starts with collection as well. I think there's a lot of inconsistencies in how we collect data, how different systems do, how providers are asking questions to actually ensure that data is accurate. And really, there's a need for training to make sure that questions are asked in an appropriate way that aren't going to further stigmatize and really let bias into the equation. So I think there's a key there. And then really making sure that we're thinking both within and without the health system. One thing that we would love to explore further as we move along here is how are we making sure that folks have multiple doors to enter different parts of the social safety net? So for example, if someone is eligible and signs up for Medicaid, are they also alerted to their eligibility for SNAP or other social safety net assistance, and really finding ways to seamlessly, while protecting obviously the privacy and security of the data, to really make sure that we're making seamless transitions for individuals, I think is a key issue, and one that will take us some time to get there, but something that we really would like to dig deeper and focus on. LeVar and I will just highlight in the chat that there are a number of willing partners on the organ transplant issue. Certainly a lot of other groups are really interested in joining your efforts, but we do have a question for you about that as well. Does AKF provide community outreach and education specifically to underserved and diverse communities on organ donation, or sorry, on donation, including living donation and transplantation?
Okay. The answer is yes, that we do. And as part of the effort that I mentioned, our health equity initiative, we will be increasing that activity. Obviously, a lot of that at this point, we used to go directly into communities, which we've not been able to do over the 2 years. But we've had a very smooth transition to conducting the sessions that we need online, as well as using partners around the country to whom we are providing tools so that they can carry on direct conversations with their various constituencies. And we will be enhancing our activities in the area of transplantation. And I think there were some specific questions that I noticed in the chat, and I did respond to those. And we can follow up later for those folks who asked questions in the chat.
Great, thanks, LeVar.
Thank you.
Gary, a follow-up to one of the points that you raised earlier about reimbursement and coverage systems, and specifically, how do we alter them? Or asking you to solve a very complex question in the 9 minutes that we have left, but any sort of general thoughts on sort of what are some of the things that need to change in terms of altering the reimbursement coverage systems so the patients can have access to gene therapies, and I'll expand that and say other sort of high touch, high value, but costly therapies that are coming down the pike?
What I can tell you is the way in which the National Minority Quality Forum is trying to address the problem. We think we have to orient our healthcare system around patient risk. Every patient who comes into the healthcare system believes and expects the healthcare system is going to lower their risk for hospitalizations, for emergency room visits, for disability, for mortality, while improving the quality of their life. Our system is not really doing that right now. It's really focused around managing financial risk. And that means that when you're focusing on financial risk, you have a tendency to create inequities. You get to the point where you think you have to ration care. And so at the heart of it, we have to think about what is the real purpose of our healthcare system. I think we get to answer the question of how we fund it when we ask the right question about what it is we're expecting it to do. And so we at the National Minority Quality Forum, we encourage everyone to take a moment and think about patient risk. Is the healthcare system actually doing that job? And if you think it's doing the right job, then I challenge you to say, what is it you think the healthcare system should be doing other than managing patient risk? And I think the answer to those financial questions will come out of that because that's where the focus of the system has to be.
Great, thanks, Gary. So we have another question that asks about if there's any place that folks can find guidance for researchers.
I'll just jump in. I see already posted to the chat is a link to this patient experience mapping tool that we'll be talking about on Friday in a major presentation. Other tools can be accessed on the National Health Council website that also speak to researchers, making sure they're focusing on the right things in the right way that really reflects that patient perspective, as Gary just mentioned. Gary, you, I'm sure, have resources that could be accessible through your website as well.
We do actually. We have been mapping chronic diseases because this goes back to that data question. Patient advocacy groups have to have data. And they have wonderful contact with patients, but here in Washington, it's just data driven. And so what we've done is we've been building a GIS system where we map chronic diseases down to the zip code level and aggregate them up to congressional district, et cetera. And we're happy to make that data available to patient advocacy groups and others. It's called MyPalc, MyPalc.com.org, I'm sorry, and we're happy to share with you.
Thank you for that. And I also noticed we had a response in the chat from Lisa Simpson, who's the CEO of Academy Health, a real contributor to our board, but also a real expert and leader in this whole area of data and certainly guidance for researchers in really getting to the right questions so we can get to the right results. So I would encourage those of you that are participating to also look at Academy Health and their website, as well as some of the resources that Lisa put into the chat that could be helpful in this area.
Great. Yeah, and I'll just underscore the point that Randy made just now and earlier as well, that we really work to make sure that we have as many resources from our member organizations and other partners listed on our website as possible. I know a number of things are currently there. We know there are other ones coming. We've been partnering with a lot of the biopharmaceutical trades, with clinical research organizations. I know many of them have other guidances and other documents forthcoming. So we'll make sure that we have them posted once they're live in public. If any of you on the line have anything like this that you'd like to share, happy to post that as well. So we'll make sure that we can get information up there for the person who wrote in with that question or anyone else who's interested in learning more. So I believe that is all we have in the chat. Certainly, as anybody has any other questions as they're kind of thinking about what you've heard today, or if any come to you as you look through the report, please feel free to reach out. If anybody's interested in joining any of our future efforts, as Randy mentioned, this is a step. It's an important step, but it is just a step on our journey as we really look to roll up our sleeves and work to achieve meaningful change. So with that, I really want to thank all of you for joining us. I'd like to thank LaVarn, Representative Kelly, Dr. Puckrin, and Randy for joining us to speak today. And thank you to the staff of the nearly 75 organizations that have helped us to date. Certainly look forward to always bringing more folks under the tent as we move forward. But thank you to all of you who have put in countless time and effort to really help us along the way. And also want to echo Randy's thanks to Jennifer Dexter and all of the NHC staff, and in particular Jennifer, who has really led a lot of, if not the lion's share of the work that we've put together today. So with that, thank you all for joining. Hopefully you get a chance to look at the report. Let us know if you have any questions, and let us know where there are areas of synergy for your organization. So we certainly love to partner with anyone and everyone as we move forward. We know this is going to take some time. As has been mentioned, we're committed for the long run. So really look forward to continuing to move this dialogue forward. I will say just personally, this has been one of the more engaging and reaffirming things that I've done in my time at the National Health Council, and certainly look forward to continuing to make this a huge priority of the NHC. So with that, thank you all. Hope everyone has a wonderful rest of the week and look forward to continuing our work together.